Good afternoon, everyone, and welcome to Second Opinion. Investigators provide perspectives on the current and future management of prostate cancer. I'm Dr. Elisabeth Heath, and I'll be moderating the meeting today. I am joined this afternoon and evening by an esteemed faculty. We are joined with Dr. Neeraj Agarwal, Dr. Daniel Petrylak, Dr. Fred Saad, and Dr. Neal Shore. As we're having a conversation this evening, we've all decided as a group to address ourselves on a first-name basis. Here are their relevant faculty conflicts of interest, and we'll just run these. And here are our commercial support for today. Research to Practice CME Planning Committee, staff and reviewers have no COIs to disclose. This program contains discussion of non-approved uses of agents and regimens. Please refer to the official prescribing information for each product for the approved indications. In order to make this meeting more relevant to participants, Dr. Love conducted video interviews with Drs. Andrew Armstrong, Rana McKay, Joyce O'Shaughnessy, and Sandy Srinivas, during which they presented questions related to topics being discussed today. Experts from these interviews will be shown throughout the program, and our faculty will provide a second opinion. So this is where we're headed today. Neal Shore will begin with non-metastatic hormone-sensitive prostate cancer. Dan Petrylak will talk about metastatic hormone-sensitive disease. Neeraj Agarwal will go over PARP inhibitors. I will discuss AKT inhibition, and Fred Saad will finish with radiopharmaceuticals. Neal?
Well, thanks very much, Elisabeth. It's a great pleasure to be here with everyone. You can see the title here, Advancing Options in BCR, Biochemical Recurrence, sometimes so-called PSA relapse, Intensification Strategies. So for BCR after local therapy, we have some different definitions for prostatectomy. It's been historically greater than 0.2. Now, how you stage, when we did Embark, which I'm going to go through here in a minute, as well as the Presto trial, it was all in conventional imaging. And the treatment after a PSA relapse or BCR could be salvage radiation plus minus testosterone suppression, intermittent testosterone suppression, and now with the advent of Embark and Presto, consideration of ARPI therapy with T suppression. Radiation therapy, you see the different constructs, and that's all based upon our prior definitions of the Nader plus 2.0 based upon Phoenix and Astro definitions, and I think that's something that's going to evolve over time and fairly soon. So here's the Embark study design. This was a 3-arm trial. We started this a little over 10 years ago, actually closer to almost 12 years now. And we looked at patients who were enriched, who had failed either RP or RT or RP and RT. So about 50% of patients had RP and RT, 25% RP alone, 25% RT alone. Patients had to have had a doubling time of less than or equal to 9 months. Really nice work by many, but particularly the Hopkins series demonstrated that rapid doubling time was rather prognostic for decrease in survival, but also predictive also of recurrent disease. You see the stratification factors. The first 2 arms were blinded, so it was ENZA, LHRH, Q3 month versus placebo and LHRH, and there was an open-label ENZA monotherapy, 160 milligrams. Of note, the FDA actually wanted us to do that. We had a stopping point at the end of 37 weeks of a PSA less than 0.2, and then if you got that low, then you would restart if you had a PSA greater than 2 for your prostatectomy patients, greater than 5 in the RT patients. That was consistent with the thought process that anything lower than that would not show metastatic disease on conventional imaging. The primary endpoint was a blinded independent central review of metastasis-free survival with key secondary endpoints. One sees the demographics here. They're nicely balanced by age, PSA doubling time, PSA at baseline, and you see all the baseline active interventions. Really good balance of about 355 patients in each arm. Global trial, of course. So this is the first primary endpoint that actually was initially presented in 2023 at the AUA, the MFS, and this showed an intent-to-treat population of looking at the combination versus leuprolide placebo, a hazard ratio of 0.42. Landmark analyses, you see the percentages listed here. The time to PSA progression for the combo versus the monotherapy, hazard ratio 0.07. And then the MFS for enzalutamide combo versus looking at the subplot analyses, different issues, whether it's doubling time, age, geographic region, baseline PSA, prior RP, everything to the left favoring the combination arm. The monotherapy also was statistically significant for MFS with a hazard ratio of 0.63 versus the leuprolide monotherapy. So the TAEs, I think, really of key significance here. Nothing really out of the ordinary of what we would have expected in enza combo versus the leuprolide. All the things consistent with our prior experience with an ARPI. But was of note was the monotherapy ARPI. You see the gynecomastia, nipple pain. But we didn't do anything prophylactic to guard against that. So that's an interesting concept, and we can do that now. We can talk about that if it comes up in Q&A. So we subsequently presented the overall survival data at ESMO this past year, Steve Freeland and myself, and really what this really showed very nicely was in addition to the prior hazard ratio of 0.42 that you see for the combo versus leuprolide alone and the 0.63 on the monotherapy, we present the overall survival data, which was a hazard ratio of 0.597. Actually, I think it's the lowest hazard ratio I've seen in any phase 3 trial for a survival benefit in prostate cancer. So here's the 8-year rate landmark analysis. So both the MFS finding and the OS was published in New England, in New England Journal. So here's the subgroup analyses, the enza combo. As you can read through it, and for purposes of time, I won't go through it, but all the different aspects, really everything moving to the left, favoring the combination. The enza mono was trending positively, but not statistically significant from a survival benefit. But certainly not, there's no detriment, but trending positively, albeit not statistically significant. And then looking at the subgroup analyses, not as profound as you would see in the combo, but by and large moving in that general direction. But there's wide confidence in intervals. Time to first use of an antineoplastic, clearly favoring the combination, even as well as with the mono, time to an antineoplastic. And this is also true for PFS as well. So the conclusion was that enza combo reduced the risk of death by more than 40% versus leuprolide alone. In patients with high-risk BCR, that's a doubling time of less than or equal to 9 months. Enza mono led to a numerically lower risk of death versus leuprolide alone, although the difference wasn't statistically significant. We actually presented here at AUA that with the treatment interruption, the treatment suspension, longer in the enza combination arm, with a survival benefit as well. Comparable treatment suspension with the enza mono and the leuprolide alone, but keep in mind you don't lower testosterone with the enza monotherapy. Significant improvements in the time to first new antineoplastic therapy, time to symptomatic skeletal events, PFS2 for both enza combo and enza mono. No new safety signals. So let's go quickly over to Presto, another very nice trial, somewhat different than EMBARK in that it was a smaller trial. As you can see, the arms here, these again were only PSA BCRs after RP, no RT population. Their doubling time less than 10 months. PSA greater than 0.5 after RP, essentially eugonadal, T level greater than 150, similar to EMBARK. No metastasis on conventional imaging. Very important, everything in EMBARK, just like in Presto, was based on conventional imaging because PSA and PSMA PET had not become so ubiquitous as it is today in most parts of the world. 3-arm trial, monotherapy ADT and apalutamide, ADT, apalutamide, abiraterone, and prednisone for a period of 52 weeks, so 1 year. Primary endpoint was different from EMBARK, but this was a PSA PFS and a rise of at least 25% above the nadir of 22. And here is the PSA PFS, successful with the ADT APA versus the ADT alone. Essentially really no difference with adding abiraterone to the APA arm. The MFS, there a hazard ratio of 0.8, favoring the combination. No real difference, in fact, even less of a benefit in the combination arm. So where does that leave us today? What the big question came as we presented all this is, well, conventional imaging has now been, for the most part, supplanted by PSMA PET. And what you can see here, and I think this nicely shows, that you'll see some patients where low volume becomes high volume with low volume conventional becomes high volume on PSMA PET. Rarely the opposite situation, except in situations where you don't get any PSMA avidity. So you have that little bit of a contradistinction. So I think it's important that when we think about high volume disease and low volume disease, how will we adjust for this appropriately in our future trials? And so here's an example of one of those future trials. This is the ARISTEP trial, and this is patients who have high-risk BCR. We let a doubling time of less than 12 months, consistent with the EAU guidelines. After you see the definitions for PSA after RP and RT. They have to be PSMA PET positive, conventional imaging negative, and they'll get randomized to Daro, approved dose of 600 milligram twice daily with ADT versus ADT and a placebo. And we'll monitor these patients. They'll be on trial for 2 years. The primary endpoint is RPFS by PSMA PET. It'll be a BICR assessment by PSMA PET, and we'll have secondary endpoints as well with conventional imaging. So this, I think, will really add to the field within in the near term. Key takeaways: intensification improves outcomes in biochemically recurrent disease. EMA and FDA have now fully approved the discussion of ADT and ENZA versus ENZA by itself. This is for shared decision-making purposes, and I think it's fantastic for that. Big fan of that. We can talk more about that. Multidisciplinary teams are the gold standard now. We'll talk more about that, I'm sure. And there are clearly a need for additional biomarkers to help us stratify who needs intensification and who doesn't. Thank you very much.
Thank you so much, Neal. Such important information, certainly an area that challenges us. We'll now hear from Dr. Love as well as Dr. Armstrong and McKay on several of their thoughts on this matter.
Good evening. In our unique Second Opinion CME format, we enlist clinical investigators to meet with me and come up with some interesting and relevant questions for the faculty. Tonight, we focus on recent developments in prostate cancer, and I met individually with Drs. Andy Armstrong, Raina McKay, and Sandy Srinivas. Along the way, I also included a comment from Dr. Joyce O'Shaughnessy, a breast cancer investigator. We begin with Dr. Armstrong.
At ASCO 2026 plenary session, Mary Ellen Taplin will be presenting the Proteus study, which is neoadjuvant ADT apalutamide for 6 months, followed by adjuvant apalutamide ADT for 6 months. All men received radical prostatectomy. Half the patients did not get apalutamide and just received ADT. My question to the panelists would be, will this change your practice of recommending high-risk patients or very high-risk patients for radical prostatectomy as compared to intensity-modulated radiation with 2 years of ADT and an ARPI such as abiraterone as per the STAMPEDE study? My second question to the panel would be, let's say you go with the Proteus approach. How do you decide postoperatively who to recommend radiation to, either adjuvant or salvage, when now your PSA is no longer interpretable? Basically, you're under ADT, ARPI therapy, you have patients with a positive margin or seminal vesicle invasion, or maybe even nodal metastases. I'm curious to see what the panel's thoughts are on the role of radiation post-op in this very high-risk setting.
If this is a positive trial, it's going to absolutely change practice. Everybody is waiting with bated breath on the results of the Proteus trial.
Okay, wow, a lot to unpack, I think, in some very thoughtful questions, anticipating the Proteus data being reviewed. Neal, I'll ask you sort of I think one of the main questions, and maybe before we get to the slide, what do you think about Andy's first question? Will Proteus upend everything you've just talked about because that really wasn't the eligibility coming in?
So, the Proteus, I'm on the Proteus trial. I'm a steering committee member, so I have seen the data, but it hasn't been presented. It will be presented at ASCO in 2 weeks' time. It is obviously a positive trial. It'll be a plenary presentation at ASCO. The primary endpoint of that trial is MFS and pathologic complete response based upon histopathology of the prostatectomy specimen. So I think it's was a very strict criteria for these patients. They were very high-risk patients based upon their histopathology. And this was centrally reviewed. I think that this will be a game changer, as Raina McKay said. I think that still there will be many patients who won't fit the inclusion criteria for Proteus, who will still end up with BCR and will still be candidates for EMBARK-type patients.
Yeah. So I think learning, from what you've shared, I think is critical. Is any change in any of our spaces, there's still ongoing patients that won't fit exactly what's been presented. Dan, I wonder, and just sort of the question here in front of us, for which patients with M0 biochemical recurrence are you recommending in your clinic on the EMBARK approach? And are you subscribing to this intermittent approach as well?
Yes to both. For a patient particularly in a patient who's had intermittent therapy previously, where they've had poor tolerance of full androgen blockade, I think the EMBARK approach is really a very, very reasonable approach to go forth with. Also, we know that the testosterone levels will rise in these patients because of the feedback mechanism. And this is one way to preserve bone integrity. And particularly in a patient who may have a baseline DEXA scan that's really not favorable, osteoporosis or osteopenia, I think this is a good approach to go forth with. So I actually favor this. I think it's a good way to go forward, and particularly in a patient who's really reluctant to go on full blockade.
Yeah. So Neeraj, I think Neal alluded to concerns about gynecomastia, nipple discomfort. I know in the old days, many of us probably in the audience and our virtual audience may have done some radiation prophylactically. Is that something we should be actively considering in our patients?
Absolutely. In patients who are really considering monotherapy with ARPI, I send them to my radiation oncology colleague to at least discuss the option of prophylactic breast bud radiation.
No, I think that's helpful because that's a practical discussion, as I think many of these things coming up will definitely impact. Fred, what do you think about sort of what's anticipated to be reported here about Proteus? Will it affect your practice?
Yeah, for sure. It'll be practice changing. I think until recently, at least in Canada, for these very high-risk patients, it was radiation and 2 or 3 years of ADT. So I think now we've done the work we needed to do to say that surgery is an acceptable alternative for these patients, and it's not automatically radiation therapy, given the fact that now we have evidence. And we have to remember, this is improving over ADT alone. Imagine if this was no treatment in combination. It would have blown it out of the water. So I think this is really practice changing and now becomes really an alternative over radiation plus hormone therapy that's been the standard of care for many of these patients.
Oh, that's really great. So go ahead, Neal.
I think just to amplify, look, for our high-risk patients, they typically get 2 years of ADT, right?
Right.
With their radiation. Yeah. And or, abiraterone, maybe you can argue enzalutamide if you look at the high-risk patients that were comparable in the ENZARAD trial. But so people will be saying, oh, wait, you're going to give them 6 months, another 6 months, but still less than a year. Most of these are going to be younger men. They're going to get testosterone rebound. They're going to get over that sequelae of the typical things that really bother, and we're all aware of that, and have arguably potentially a greater clinical benefit going on. OS is going to be immature for sure, right? We got to wait and follow that, but I think this is the first time we're going to see the first perioperative regimen in RP of any value at all.
Oh, absolutely. Dan?
So I think what we're seeing here is this trend of getting more intense treatment up front. We saw this with all of our studies with hormone-sensitive disease with metastatic patients. We saw that adding an antiandrogen increased the survival. Previously, all the trials had failed in this particular spot. So we're using really modern generation AKT to show that we have a benefit. It's just simply an extension of the concept of moving things up earlier.
It is amazing that we've never really for years used the term treatment intensification, and now it's everywhere in our literature, in our standard practice, and I think there's so much to look forward to with the ASCO study. Fred, any upcoming studies that we should now be on the awareness path of, especially now with Proteus sort of on everybody's radar? Should we be looking at enrolling neoadjuvant studies, and what's happening outside of Proteus that we in the audience should be mindful of?
Well, I think, between Proteus and Embark, we're really realizing that, as everybody was saying, that patients who are destined to become metastatic, at risk of metastatic disease and death, really needs to get the optimal treatment. We're talking about intensification, but I think more and more of us are using the word optimization rather than intensification. This should be now the new standard for these patients that are really at high risk of progression and actually dying of prostate cancer.
Mm-hmm. Oh, I love that distinction. I think for our audience, that's really important. We're now getting into the finer points of this for patients. I know many of us talk about de-escalation of doses as well. That's really top of mind for all of us. Well, let's move on to our second video with Dr. Love and Dr. Srinivas.
In my chat with Dr. Srinivas, I asked her about exciting new developments in androgen pathway modulation, and her answer was fascinating.
It's a new study that came out of the UK. It's called the PATCH study. It's using estradiol transdermal. They have to put 2 to 3 patches 2 times a week. And when compared to Lupron, it showed identical efficacy. But the big advantage was that there is less issues in terms of heart and bone loss because it's bypassing the liver. It's transdermal. DES used to be a very standard treatment that was used for prostate cancer 3 decades ago, but had a lot of problems with DVT and thrombosis and also cardiac issues, so it got taken off. But now instead of oral, because it's given through the skin, it bypasses the hepatic system. So there are less cardiac effects, there's less bone effects. It's very early in its adoption. I've used it for people who have had severe osteoporosis. The big issue is hot flashes are less, but people have more gynecomastia with this, just similar to enzalutamide monotherapy. So I think the new kid in the block for prostate cancer is the estradiol patch.
What a very interesting discussion. I think many of us who have patients who come with us with this question, myself included, it's really quite a challenge trying to sort of integrate what was known before with DS and other estrogen-type compounds, and perhaps our concerns with clots and things. So Neal, what do you think about this study, and would you prescribe sort of an estrogen provided in a patch for your patients?
Yeah, I think this is a great study because, especially when you put on your hat of a payer or healthcare system, it's really inexpensive. Of course, permanent testosterone suppression with surgical orchiectomy is very inexpensive after a period of several months, as long as the patient survives. But it's a very morbid procedure. These all accomplish pretty much the same thing. The transdermal estradiol patch has the advantages, as Dr. Srinivas points out. and she didn't even get the economics of it is really very dramatic compared to the traditional parenteral formulations we have and even the oral formulations we have for androgen deprivation therapy. Those VA cooperative groups trials that Byers was the author on, they really mostly looked at 3 milligram and 5 milligram. I've always thought, I had an attending when I was a resident who wrote a lot of letters on this. You could, for some patients, they might do really well with like a milligram or 1.25 milligram, but no one's really studied that at DES. It's very inexpensive and very simple. But there is the worry about cardiovascular toxicity and VTE. I think it's really to Noel Clark and Silke Gillison who really helped get this through. I think it's very interesting. One of the challenges is you got to put the patch on. You can worry about contact to contact with your partner. But overall, I think it's quite provocative.
Yeah. Dan, what do you think? Would you do this, and do you think insurance will approve it? I mean, none of this is technically available right off the shelf.
You can't get any estrogen compounds right now in this country. In fact, yes. I don't even think you get estromustine anymore. In DES, certainly we can't get, except through especially pharmacy or compound pharmacy. But I think it's a very reasonable thing to go forth with, again, from the issues I mentioned before. Bone loss, fatigue, those seem to be better with this patch. The question is, are you going to be able to get the same testosterone rebound if you did intermittent therapy with this patch? That's one question which I don't think we have an answer to. But certainly I would consider this as an option for our patients.
Yeah. Neeraj, what about you?
Kudos to the investigators for doing this trial. And as Dr. Srinivas mentioned, this bypasses the liver, so cardiovascular issue is not that much of a concern as it was with the old generation estrogen. So I can clearly see some indication for patients who have severe bone loss to begin with, who have osteoporosis, osteopenia. I think it will be a great agent for them. From cardiovascular perspective, I think GnRH antagonists are really attractive to me, relugolix-like drugs. So I'll probably lean towards those agents rather than estrogen patch.
Mm-hmm. And how about you, Fred, outside of the U.S., thoughts?
So I don't want to repeat what everybody said, but I think one of the other advantages is the hot flashes, which is a huge issue for some patients. And this, I think, can bypass some of this. And for gynecomastia, which is clearly going to be an issue, we actually use tamoxifen when patients are using monotherapy and found it to be more effective than radiation therapy, as other studies have shown.
Yeah. No, that's really great. Neal?
I love that Fred brought that up. Thank you, Fred. I mean, I've talked with Fred about this. Rather than the radiation therapy, which is effective, 8 to 12 gray over 1 to 2, 3 days, but tamoxifen is generic. And I'm talking with Nick James in the UK, 10 milligrams like every 2 to 3 days really dramatically mitigates all the breast-related symptoms.
Yeah. So it's really interesting, and I think from the audience, whether it's you all here in front of us or virtually, I'm sure you're experiencing similar type questions in your practice. Because these are what really is important at times from a patient perspective. So kudos to those folks who completed this study. We won't be able to get to the second question, as now, Dan, we ask you to go ahead and present your presentation on current hormonal therapy for mHSPC.
Thank you, Elisabeth. So we're going to be talking about current hormonal therapy. And as we know, we now consider doublet or triplet therapy for patients with castration-sensitive prostate cancer to be standard of care. When we start looking at the hazard ratios and the overall survivals for doublet therapy and triplet therapy, for doublet therapy we seem to have very, very similar types of hazard ratios for progression-free survival. We see this with Latitude, where abiraterone has been used, Stampede, abiraterone as well, Arches with enzalutamide, Titan with apalutamide. We've also seen the same thing with darolutamide as well. In terms of triplet therapy, PEACE-1 and Arasense also showing hazard ratios of 0.68 to 0.75 respectively. But again, the question is, which are the right patients to go forth with doublet and triplet therapy? This was a presentation from Andy Armstrong about a year ago at ASCO, where he looked at the final survival analysis from the Arches trial that compared enzalutamide plus ADT to placebo plus ADT. Now remember, in this trial, when it met its primary endpoint, patients were allowed to cross over if they were just simply on ADT alone. As we see here, the hazard ratio is pretty much preserved at 0.66 with this extended follow-up, despite the fact that you're giving the other anti-androgens in the control arm. So I think that's pretty impressive confirmation that this is real data. Moving on to the Arisens trial, where we've combined darolutamide plus ADT plus docetaxel versus docetaxel ADT. This trial looked at metastatic castration-sensitive prostate cancer in 1,305 patients. It was a double-blind trial. They all received 6 cycles of docetaxel in each arm. As we see with Arisens, the overall survival does seem to be better with the combination therapy. 43 months median follow-up in darolutamide, 42 months in the docetaxel group. The hazard ratio, the median survival was not reached in the combination arm. Darolutamide plus placebo was about 50 months. Hazard ratio is 0.68. This seemed to be present irrespective of the fact of patients having high-risk or low-risk disease, consistent with both of these studies. Safety, as we look at the safety, I think the darolutamide does seem to have better tolerance than some of the other anti-androgens. There's less fatigue. We really didn't see any addition to toxicities with docetaxel when you combine that with darolutamide. ARANOTE looked at darolutamide plus ADT versus ADT alone. This is doublet versus single-agent therapy. And again, about more than 600 patients were entered in this trial. The primary endpoint was progression-free survival. Overall survival was a secondary endpoint. This is from ESMO 2024. Darolutamide significantly reduced the risk of radiographic progression by 46%. It was 70.3% of patients who did not progress at 2 years versus 52.1% of patients who only received the androgen deprivation therapy. It's important to note that we're still not doing as well as we should in terms of getting all these patients on doublet or triplet therapy. It's about 60% now. It should be close to 100%. And I'll explain some of the reasons why in a few moments. If we look at different characteristics, they all seem to be in favor of the combination therapy. With low-volume disease, the patients did seem to do somewhat better than the high-volume disease patients, but nonetheless, again, all seems to favor darolutamide in this particular setting. If we look at other endpoints, overall survival, hazard ratio 0.81, time to metastatic castration-resistant disease, hazard ratio 0.4, PSA progression 0.31, initiation of subsequent therapy, 0.4, and then time to pain progression, 0.72. Safety, if we look at the side effects, very similar in both arms, in the placebo arm versus the control arm, 30% grade 3 or grade 4, 4.7% grade 5, and treatment-related adverse events were lower in the combination arm than they were in the placebo arm. The big difference we see here is with fatigue. There's slightly more fatigue with darolutamide, 8.1% with the placebo and 5.6% with the darolutamide. Again, close, but this is not really the additional fatigue that we see with some of the other anti-androgens. So we're left with a dilemma. We've got these randomized trials that are showing us very similar hazard ratios in terms of RPFS. How do we select treatments? And I think the best way to think about this is in terms of complexity of the treatment as well as the possible side effects. Abiraterone is now generic, but you have to monitor patients carefully, particularly liver function tests, hypertension. There does seem to be less fatigue with abiraterone with the other agents, and it is one of the agents that you can intensify the triplet therapy. Neurocognitive events occur with enzalutamide. One of the ways that you may overcome this is by giving the drug at nighttime. With apalutamide, you have rash, which is an issue. Also, same thing with neurocognitive events. Darolutamide, same thing, less monitoring, less fatigue. You can intensify that. And docetaxel is no longer used as a single agent, or at least in the NCCN guidelines. So, again, management. Watch blood pressure. Watch for falls and fractures. Try to prevent that. Give calcium and vitamin D to overcome the bone loss. As I mentioned before, take darolutamide or any of these drugs, since it's a BA drug, but enzalutamide before bedtime. Use topical agents for the rash, and then GI events are also important to monitor diarrhea, nausea. With the agents that don't cross the blood-brain barrier, like darolutamide, seizures are not as much of an issue. Apalutamide and enzalutamide, perhaps they are. And then cognitive impairment seems to be less with darolutamide as well. Apalutamide, you have to monitor for hypothyroidism, check your TSH at baseline. So is there some data that can help us decide what to do, particularly with elderly patients, particularly with patients with other comorbidities? Well, STOPCAP is a meta-analysis of 7 of the 11 hormone-sensitive prostate cancer trials, which compared ADT plus an ARPI to ADT alone. It's close to 8,000 patients, or 70% of all trial patients that were entered in these studies. This was an intent-to-treat, 2-step analysis looking at different covariates such as age, PSA, performance status, Gleason score, timing of diagnosis, and the use of concomitant docetaxel. The main effects were based on overall survival, and there were interactions that were looked at in terms of progression-free survival to look at the different powers of the particular agents that would be looked at. So these are the characteristics of the different trials. About half of them had high-volume disease. Most of them had synchronous metastases. The enzyme seemed to have the lowest at 68%. And 2 trials, PEACE-1 and Enzymet, as well as Titan and Stampede, all these had docetaxel. So what about the addition of an ARPI? Nothing really spectacular here. We know that the addition of an ARPI will improve progression-free survival by 21% and overall survival by 13% at 5 years. There was no clear difference when accounting for volume or location of METs, Gleason score, or timing of metastatic diagnosis. But I think there's an interesting pattern that arises here when you look at the ARPIs in terms of PFS and OS by age group. So if we look at the ARPIs that favor as far as age of 75, we start seeing that the hazard ratio starts moving towards 1 overall. They're very similar with the 65-year age group and 65 to 75. When you start looking at the abiraterone trials, this seems to be the culprit. Those patients over the age of 75 seem to do not as well as the ARPIs in the other ARPIs in this particular area. 65 and 75, they seem to be very, very, very similar, or 65 to 75. They seem to be similar. And when we start looking at just simply what's called the AMIDs, enzalutamide, darolutamide, apalutamide, they all seem to be very, very similar in terms of their PFS and OS differences. So just to summarize, the 5-year absolute effects of the RPAs by age group, with the younger group, you're seeing about a 25% improvement in progression-free survival, about a 16% OS difference, but the oldest age group, it tends to be a little bit different. And again, you're seeing with the abiraterone data, you're seeing actually a worse outcome than you are seeing with the other patients. So there's a clear benefit for androgen receptor pathway inhibitors on overall survival and progression-free survival for the majority of HSPC patients. Side effect profile should be considered when you're selecting an ARPI. For younger patients, there's a clear benefit for all anti-androgen receptor inhibitors, but for the older patients, we have to think about abiraterone and consider the AMIDs as a more reasonable treatment probably because of the cardiovascular events. And I got 20 seconds left.
Thank you so much. Fantastic. I think that was such a wonderful review on a really emerging topic, and maybe as we listen to Dr. Love discuss with Drs. McKay and Srinivas, we'll also think of additional questions to pose our panel.
One of the most discussed recent studies in androgen pathway modulation was the EMBARK trial, and our consultants are interested in feedback on several related issues in the metastatic setting.
First question is, do you do intermittent therapy in the BCR setting, and would you give it an attempt in the metastatic setting? What context? We're going to see data that are going to be presented from a trial called ADREAM that was run through the cooperative groups that enrolled patients with metastatic disease. And if they achieved an undetectable PSA at around the 18-month mark, they could stop their ADT treatment and their ARPI and be monitored. And then at some time point, based off PSA, could be reintroduced. So is this something that you think has legs? Is it palatable in the metastatic setting?
I would like to ask them about the concept of intermittent therapy in this metastatic hormone-sensitive de novo disease. De-escalation, stopping at 2 years. Are they stopping only one drug? And what is their threshold to restart? And if they were to design a study, how would they design that?
Okay, lots of questions to unpack there. Dan, perhaps just sort of the main question that I know our audience here and virtually always want to know, which is, do you stop and start in the mHSPC group? And if so, in what setting do you?
Well, I've had some patients, and this has been a patient-driven question because we really don't have a lot of data. And remember, the SWOG data showed originally that those patients with low-volume disease and the very high-volume disease patients did make a difference whether you give it continuously and intermittently. The ones in the middle was where they had some issue. Yeah. So now that we have PSMA PET scanning, we can actually look and see whether patients still have residual disease. And one thing I've actually done is see if there's residual uptake at that particular point. I'm comfortable having a discussion with a patient at that time, especially if they're younger, because we have long periods of time where they may develop side effects, the osteoporosis we talked about before, muscle mass, and sexual functions. All of these come into play. But if a patient's PSA is 0, the imaging is negative, I think it's reasonable to discuss this with the patient at that point.
And I highlight on this slide, it's known as androgen pathway modulator sensitive metastatic disease. For those of you who are following with Prostate Cancer Working Group 4 manuscript, we are trying to really perhaps move away from the term castration, either sensitive or resistant. So you'll start to see this new wording in many of the discussions and manuscripts coming up. Fred, I wonder what your thoughts are on how your approach is.
Yeah. So, this has been a question that we've been asking, and Canada led intermittent versus continuous trials that we published in New England in 2007. So this is not a new concept. And at least for the non-metastatic setting, at least non-metastatic on conventional, for us it's pretty much the standard of care to be doing intermittent. And now, based on EMBARK, we can do better intensification and get a longer period without treatment. In the metastatic setting, we did a trial also that showed it was very similar, maybe slightly inferior, but borderline. And that was in an era where stopping therapy just required that PSA went below 4. It's not something we would do today, right? We're talking about going to undetectable levels, making sure that there's no visible lesion. At the time we did the study, we didn't know the importance of PSA nadir. So just getting to below 4 was enough to stop therapy, which we would never do today. So I'm very comfortable, but this is a shared decision-making. We don't have level 1 evidence, and patients are the ones that are going to take the final decision. But after a couple of years, we're doing this more and more, and now we're starting trials where we're going to actually randomize to continuous versus stopping. And I think we're going to have an answer. But until then, I think it's very reasonable as a shared decision-making.
Mm-hmm. I think the concept of shared decision-making is growing in many of the aspects of our prostate cancer practice because we actually have options to talk about with patients. So what a wonderful place to be. Neal, many of us, if not every single person on this panel, has done everything we can to get the word out on treatment intensification. Who are the patients in your practice that you don't intensify?
It's in my experience, it tends to be more patient-driven. So I'll start them, for example, on a testosterone suppressor. Typically, if they're reluctant to get an ARPI, I'm very happy to recommend, because they're worried about side effects and toxicities, and I put them on relugolix, and then have them come back and they'll and see how they tolerate that, and then I explain, well, if you're tolerating that okay, and polypharmacy is not an issue, there's not a DDI issue in any of the approved ARPIs, I will try to then layer that in. But sometimes the patients who insist on being on ADT alone, it's rarely an economic thing. Sometimes it's that, which I have to respect economic toxicity, and sometimes it's just the patient decision. But I always, 100% of the time tell them the data supports doublet therapy.
Mm-hmm. Well, and I think for everyone here, just not too long ago, maybe that rate was barely 20% in terms of intensification. As Dan, you mentioned, we're hopefully up to 60 and growing. So it's education programs like this and conversations we're having with one another to encourage that shared decision-making moment. We are actually going to move on to Dr. Armstrong, because he's going to ask also a question with his conversation with Dr. Love.
This past year has resulted in an explosion of phase 3 trial data in what used to be called hormone-sensitive metastatic disease. Dr. Armstrong is curious about where you land on resulting clinical algorithms.
We've got 3 new triplets that have been presented. You've got the ADT-ARP-PARP triplet, you've got the ADT-ARP docetaxel triplet, and you've got the ADT-ARP capivasertib triplet, which is not yet approved but got a favorable ODAC ruling just this past week. Not to mention the 4th triplet, which is PSMA lutetium in PSMA-positive hormone-sensitive patients. The PSMA addition also showed a significant delay in progression. So I guess my question is, with these 4 triplets, what will be your preferred triplet, and in which patients? In the PTEN null patients, will you integrate capivasertib into your treatment algorithm? Would you consider capi with an ARPI post-docetaxel, even though that wasn't studied in the Capitello study? Would you consider PSMA lutetium as a quadruplet, following docetaxel and ADT-ARP? So this is kind of the art of medicine. We don't have data on quadruplets at all, but I'm interested in the panel's approach in these really aggressive patients who fail to have a really nice response to doublet or triplet therapy.
All right, lots of questions there. Neeraj, what do you think the answer is to his questions?
First of all, I love the fact that we are talking about so many options for our patients with metastatic hormone-sensitive prostate cancer. And the question is, just coming to the point of the question, we have capivasertib-based triplet, PTEN deficient patients, for PTEN deficient patients, PARP inhibitor-based triplets for HRR deficient patients, and PSMA lutetium-based triplets for patients who have high PSMA expression. And how to dissect, how to choose the right treatment. I think we will see the data emerging in a very near future. They're already emerging from the retrospective studies that PTEN deficient patients don't really respond very well to the PSMA targeted therapy. And in our own study we published just a few months ago, PTEN deficient population was exclusive of HRR mutation positive population. So I see a paradigm emerging here in patients with metastatic HSPC who are PTEN deficient. They are high level of PTEN deficiency. They will likely get capivasertib with ADT plus ARPI. On the other spectrum, HRR deficient patients who are about 25 to 30%, they will get ADT plus RP plus PARP inhibitor. And somewhere in the middle are patients who will get lutetium-based therapy or docetaxel-based triplet. That's how I see field emerging.
Yeah, absolutely. We're getting into the weeds, which is a great place to be, because then we're offering much more individualized therapy for patients. I do have an in-person audience question. And
before you get to that, so we talked about where everybody's excited about ASCO, and we're going to see the Proteus, but we're going to have Neeraj present TALAPRO 3. Spoiler alert, it's a positive study. He'll be doing a really great presentation.
Fantastic.
And I think it's going to really add to that triplet combination. We saw the amplitude last year at ASCO with Gertatard. So I think this is going to be great. And then kind of adds to the importance of genetic testing.
Oh, absolutely. And I think maybe before we get into sort of the genetics, there's a question in the audience. In some sense, we're talking about triplets using abiraterone and darolutamide. What about the other ARPs? Are they substitutable? Fred, would you substitute enzalutamide in there? Would you substitute apalutamide?
Well, I think it depends with what we're going to combine. What was nice about PSMA addition, it was dealer's choice to use whatever ARPI they wanted. So we've got clear safety that you can combine any ARPI. Now, would I do that with a PARP inhibitor? I think there we need to have the data. Can we combine olaparib with something else besides Abi or niraparib? or something else, talazoparib with something else besides ENZA. I think we would need to be safe, and I wouldn't play around with a PARP inhibitor combination, same as an AKT inhibitor, until we have some safety as to what combination would be safe and efficacious.
Mm-hmm. Dan?
So it may be that the enzymes related to PARP inhibition or the different PARP characteristics are different molecularly with different antiandrogens or perhaps different with abiraterone. So I don't think we can make that leap of faith saying that they're all equivalent in the situation. We know that one's paired with the other. We know that there's efficacy in that particular situation. It should stay that way.
Yeah. No, great question from our audience. Thank you so much. For others, please feel free to submit them, and for our virtual audience as well. Neal, in your practice, we're talking about now really finessing, these different groups of patients in the mHSPC or the APMS group. What's your standard algorithm? Are you doing germline testing in everyone, somatic as well, liquid, tissue, both?
Yeah, 100%. I've been doing for the APMN and the APMS, formerly known as mHSPC. I am doing 100% germline testing, 100% somatic testing. I think that should really clearly tissue for the somatic whenever I can get it, which is most of the time. But because I think it just really helps me identify all the different tools. If you just do germline and you stop, you'll miss 50% of the other alterations. And then the other reason for doing the germline is to make sure you could do cascade family education. It's incredibly important.
No, absolutely. And I think, Neeraj, we can have you come up and talk about the role of PARP inhibitors. We'll talk more about genetic and genomic testing as we now move towards PARP inhibitors.
So I'll start with the incidence of these homologous recombination repair gene mutations, and either in somatic or germline testing. And we can see here, this is one of the seminal papers showing 11.5% of patients with metastatic prostate cancer had one of these mutations. These are inherited mutations, and that makes it so important for us to order testing for all patients with metastatic prostate cancer. And then if you look at the somatic or tissue testing, we looked at more than about 3,500 patients in the Foundation Medicine series. And again, very similar thing, a very significant number of patients, 25 to 30% of these patients had one of the HRR mutations. So you combine them, we are talking about 1/3 of patients harboring either germline mutations or somatic mutations in when they have metastatic prostate cancer in HRR gene pathway. So what is the optimal method for genetic testing? I would make it very simple. We put together in the ASCO guidelines last year that all patients should be offered germline testing as well as somatic testing. This is not only important for the patient's treatment, especially with the newer data coming up, as Dr. Shore mentioned, in ASCO, and last year we saw abiraterone plus niraparib data, but also to assess the impact on their family. Personally, I have been witness to medical legal issues where these patients were not tested and their children were later diagnosed with one of these cancers which are associated with germline mutations. It would be very difficult to justify why I did not test the dad who had metastatic prostate cancer. Any tissue is good, any ctDNA. Just a caveat, when I look at the ctDNA testing, I like to do that when patients' PSA is still high. Once we have started them on an ADT and PSA has gone down, the ctDNA testing is usually not very productive. So any tissue is good. The key is to get those testing done, get them ordered. Now I'll switch to the combination of PARP inhibitor and ARPI. The way I explain to this patient, or patients, I simplify the whole concept. I tell them when we hit these prostate cancer cells with AR-targeted drugs, PARP comes to the rescue of these cancer cells, and PARP level goes up. So when we inhibit PARP and AR at the same time, they tend to cooperate with each other and enhance the cell kill in prostate cancer. And these are the 3 trials which have been reported in the metastatic CRPC setting in the last 3-4 years. And you can look at globally looking at them, they all look very similar. They have nuances, there are differences. All of these trials were in metastatic CRPC setting in the first-line setting. All of these patients were randomized to ADT plus ARPI plus minus a PARP inhibitor. And if you really dissect the data, this is a very crowded slide, but I'll bring your attention to the overall survival. In the TALA-PRO-2 trial in patients with HRR mutations, treatment with enzalutamide plus talazoparib resulted in a 14-month improvement in survival compared to enzalutamide alone in mCRPC setting. And that's one of the highest magnitude of survival benefit we have seen with any drug in metastatic CRPC setting. Even in the PROPEL trial, which barely misses overall survival, the radiographic progression-free survival was quite remarkable. So coming to these trials individually, if you look at PROPEL trial, by adding olaparib to abiraterone backbone, we see a 50% reduction in risk of radiographic progression, and even though overall survival was not positive, it was trending pretty strongly. If you look at the side effects, all these PARP inhibitors are very similar, some non-overlapping side effects to some degree, but in general, all of them cause some hematologic toxicities. Olaparib has some more GI toxicities, nausea, vomiting, and diarrhea. If you look at the other side effects, they are not as common. And most common way to deal with these side effects is to monitor these patients upfront. First 3-4 months, I see them every 15 days. And pretty much anyone with grade 3 or 4 side effects will respond very well with timely dose reduction. And most of these patients in this trial or a BRCA trial we did with the combination were able to tolerate combination for months to years if they had predisposing mutations. Now coming to the magnitude trial, this trial was slightly different in the sense that they randomized patients based on whether they had HRR positivity or they had HRR negativity. Overall, niraparib with abiraterone combination resulted in a significantly improved benefit with radiographic progression-free survival, most pronounced in BRCA1 and BRCA2 mutation-positive patients. Overall survival was not positive overall. And again, the side effect profile, we see cytopenias which respond very well to dose reduction in a timely fashion. This drug also has some unique cardiovascular side effects such as hypertension. It was combined with abiraterone. Hard to dissect what was contributed by abiraterone versus niraparib, but something to keep in mind. Check blood pressure on a regular basis, and these patients require frequent monitoring to look for liver enzyme elevation with abiraterone. So whenever they come to the clinic, we check their blood pressure, EKG, otherwise fairly tolerable regimen. Coming to the TALA-PRO-2 trial, as I mentioned, enzalutamide plus talazoparib, the only trial with overall survival benefit in both HRR unselected and HRR mutation positive patients. And this benefit was present in patients who had HRR mutation or they did not have HRR mutation. We have the label for patients who have HRR mutation, and the benefit was quite pronounced in both BRCA1 and BRCA2 versus non-BRCA1, BRCA2 patients. The side effect in this case is mostly hematologic. So grade 3 anemia is much higher, but then you look at nausea, vomiting, they are much fewer as far as grade 3 or 4 nausea and vomiting is concerned. So again, very similar profile, but slight nuances as far as toxicities are concerned. And most of these patients are able to tolerate this combination for months to years as long as we are able to reduce the dose of talazoparib in a timely fashion in those patients who are developing grade 3-4 side effects. So again, just to summarize the management of side effects, close monitoring in first 3-4 months, and reduction of the dose of PARP inhibitor to next level allow most of these patients to tolerate the regimen for months to years. The dose intensity of talazoparib was very high despite dose reduction in about 90%. Median dose intensity was 90%. So overall, well-tolerated combinations. This is a summary of these trials. We can see abiraterone plus olaparib and talazoparib plus enzalutamide combination seem to have, again, cross-trial comparisons, higher efficacy than the abiraterone plus niraparib combination in BRCA patients as well as in the non-BRCA HRR mutation-positive patients. Now coming to the hormone-sensitive setting or APMS setting, Hormone-sensitive is recently changed to APMS. I'm so glad we got castration word removed for the terminology. And in this trial, patients were randomized to abiraterone plus minus niraparib. And these patients had to have been on androgen deprivation therapy, and docetaxel treatment was allowed. Only 16% of these patients received docetaxel chemotherapy prior to enrollment in the trial. We can see the benefit was largely driven by BRCA1 and BRCA2 mutation-positive patients. And even if you look at, we don't have the data on those patients who did not have BRCA1, BRCA2 mutation. That data is not there, not presented yet. But overall, the PFS was significantly improved with niraparib. The label includes abiraterone niraparib for only those patients who have BRCA2 mutation in the US. If you look at the overall other clinically meaningful endpoints, they also favored the combination, again pretty much driven by BRCA1 and BRCA2 mutation positive patients in my view. So you look at phase 3 TALAPRO-3 trial, again a hormone-sensitive trial. Here, patients who were receiving ADT therapy were randomized to enzalutamide plus minus talazoparib. Radiographic progression-free survival is the primary endpoint. There was a press release by Pfizer that trial met the endpoint, and we hope to see the data in the near future in a meeting. I would like to also mention or give a shout out to some new PARP inhibitors which are coming up, and as you can imagine, all these PARP inhibitors are not same, as all ARPs are not same. Saruparib is more potent PARP1 selective inhibitor, has less inhibition of PARP2. So we are really hoping that we will see less hematologic toxicities with this trial. We are conducting this trial in the metastatic hormone-sensitive setting in patients who have HRR mutation versus who do not have HRR mutation. And of course, results will tell down the line whether how strong saruparib is from the efficacy perspective and toxicity perspective. Of course, there are new challenges coming, how to dissect the mechanism of resistance for these PARP inhibitors, whether we can re-challenge them with PARP inhibitors when they have progression with a different PARP inhibitors or different combination of PARP inhibitors. For example, patients who receive abiraterone plus niraparib, can they receive enzalutamide plus talazoparib in mCRPC setting? We don't have those answers yet. But bottom line is PARP inhibitor have role in the treatment of metastatic castrate-resistant prostate cancer and in metastatic hormone-sensitive prostate cancer. Thank you.
Thank you so much, Neeraj. So much there to discuss that we'll get to, but let's hear from Dr. Love when he's talking to Drs. Armstrong, Srinivas, and McKay on this topic.
The first new triplet combination for androgen pathway modulation-sensitive disease is the use of PARP inhibitors in addition to hormonal therapy, initially with niraparib and abiraterone and androgen deprivation therapy.
At ASCO 2026, the TALAPRO-3 data will be coming out with talazoparib and enzalutamide. So I guess I'd ask the panel, how will this change your practice? And then another question for the panelists is, assuming TALAPRO-3 is positive for an all-comer HRR positive group of patients, and the Amplitude study is only positive for BRCA2, how will you decide which PARP inhibitor and which ARPI combination to use for your patients?
I think a young patient who has high volume disease, who is BRCA2 positive, a lot of people would make a case for a PARP inhibitor. And then I think the question is, what is the duration of PARP that they would do? Which of the HRR are they most excited to use it on? Is it PALB2? Is it CDK12? ATM comes up all the time. And I would even pose this question, Neal, because there is a trial called Triple Switch, which looks at patients having ADT and a doublet. And at 6 months, if they don't achieve an undetectable PSA, there is an opportunity to add docetaxel. I'd be curious if they would do that for PARP. Where you're selecting out people who are likely to have a worse outcome, and you're not waiting till they become CRPC, but could there be an opportunity to add on to a PARP at that point?
The other trial that I'm actually super excited about, and I think we as a field need to all get behind, is actually EVOPAR-2. EVO Part 2 is looking at adjuvant saruparib for patients with localized high-risk disease that have a BRCA1/2 alteration, whether it's somatic or germline, randomizing to adjuvant ADT saruparib versus just ADT. This is an opportunity for us to potentially increase the cure rate of patients who have a biologically more aggressive disease phenotype. The breast cancer community has already done this with the Olympia study.
There's a lot there, but I'm going to take our audience question first, which really is fantastic in terms of, I'll ask Neeraj, since we're knee-deep into molecular testing, how many times is HRR testing needed? And is there a difference in the type of testing? And perhaps some clarification with that would be helpful to this audience.
Yes, all patients should be offered somatic as well as germline testing. Regarding the type of testing, the availability, pretty much universal availability of this comprehensive genomic profiling has actually made our job much easier. We don't have to do point testing. We don't have to worry about ordering individual genes. I think that actually deplete the precious tissue. So all these patients, wherever I order HRR testing, I order comprehensive genomic profiling through a CLIA certified lab. It could be Foundation Medicine, Tempus, any of this. Yeah. And all of them are good, I think.
Okay. Dan?
These are genetically unstable tumors. There's no question about that. And we actually published this from the rucaparib study, that one patient who was initially BRCA negative by somatic mutations turned out to convert to a positive mutation later on. I've seen that happen a couple of different times. So what I generally do is if a patient has a change in their clinical status, let's say if they start rapidly progressing, if they go from non-visceral to visceral disease, that's the patient I'm going to retest because I suspect that they may have a change in the genetic profile.
Mm-hmm. No, thank you for that. And that was the audience member's second question in terms of when would you retest. Fred, in your clinic, knowing everything that Neeraj has just shared with us in this landscape, first, do you really now just start looking at BRCA2 patients in the mHSPC or APMS group? Are you broadly prescribing? What's your approach?
Well, I think it only makes biological sense that somebody like a BRCA mutated patient, there's no need for them to wait to have become mCRPC and failed an ARPI. I mean, we saw that in Profound, that patients who got it before chemotherapy did better than patients who got it in the third line. And now we have data that up front, we bring patients who are destined to die quickly back up to the survival of patients without a BRCA mutation. So it just makes biological sense that if we know these patients have this mutation and they're hormone-sensitive metastatic, that we should start at that point. Now, the question is how long? I think for life, it might be too long, and that's something that we need to start thinking about because we don't want to expose these patients who do well for 5-6 years to a PARP inhibitor for multiple years. But that's another question that needs to be answered.
No, absolutely. And Neal, since we are at the AUA, now we're talking about intensification of additional agents that just come with it, an additional host of side effects and management strategies. Is this something that the urologist should be thinking about expanding their practice? Is this something that should be a combined approach with medical oncology? What's your thoughts on that?
Yeah, absolutely. For the urologist, the uro-oncologist who is dedicated to already doing doublet therapy with an ARPI, and they're familiar with the side effects of the various ARPIs, getting educated on understanding the management and the explanation to patients and their families regarding the GI and the myelosuppressive effects that Neeraj did a really great job in reviewing. And they vary amongst the different PARP inhibitors. The testing, the Q1 month CBC, I think is absolutely, but it's not for the dabbler. It should be somebody who is very dedicated to it. And if they're not, they should be working very, very closely with their medical oncologist. Just one other quick point. You germline test only once.
Yes.
A one-time test.
No, that's a terrific clarification because I think that is a nuance that sometimes in our messaging gets a little mixed. So thank you for pointing that out. And also for recognizing that the urology practices are also as diverse as the medical oncology practices, whether they're community-based, academic, and whatnot. So we're, I think, very fortunate to have such diversity. When we're thinking about how to prevent maybe some of these side effects or address it, Neeraj, you listed, many points in here. Anemia we're aware of. What should we do in terms of spreading the word so that folks are prepared? I mean, being able to identify the mutation, maybe selecting a treatment plan is one thing, but then having to actually treat patients and work with them, what's your strategy?
So for the GI toxicities, I don't send them out, especially when I'm prescribing olaparib, which is most commonly associated with GI toxicities, without antiemetics, and pick your dealer choice, whatever you want to pick. Just tell the patient not to wait for grade 3 nausea and vomiting to happen. And it is often quite easy to control nausea and vomiting with antiemetics. If they don't respond, I decrease the dose, and I have rarely had to discontinue a PARP inhibitor because of GI toxicities. Same applies to anemia. I make sure these elderly patients have vitamin B12, folate, iron level tested before they are starting PARP inhibitors. I do the same thing for docetaxel chemotherapy. And after ensuring they are not deficient of those critical ingredients which can predispose them to anemia, I regularly follow their CBCs monthly on talazoparib. And I will know within 2 or 3 months who is on track to develop grade 3 anemia. And unlike protocols, I don't wait for grade 3 anemia to happen. I reduce the dose in those patients before they hit grade 3 anemia. So in real-world practice, we rarely have patients who need blood transfusion or who develop grade 3-4 anemia, unlike protocol treatments where we have to meet some level before we can reduce the dose. So that's my take on toxicity.
Yeah, and what I hear is basically active management to try to prevent and then quickly address and not have to struggle through when it's an emergency, because that's when I think people are worried. Fred, there's this mention about EvoPAR, saruparib. Are all PARPs the same? Do you approach them the same, or do you actually think of them differently, as perhaps Dr. McKay was alluding to?
Yeah, clearly PARPs are not all created equal. I think we already got a glimpse of that between niraparib and the other 2 PARP inhibitors. There are different drug-drug interactions. I think we can't hide behind the fact that there looks to be differences in efficacy. Mm-hmm. Now, what we're hoping is that with a more specifically targeted PARP inhibitor, that we might get away from some of the hematological impacts, but that needs to be still proven. We're going to look at that. But so far, the patients are blinded, and the experience has been quite good with the EvoPAR trials. So looking forward to seeing the data unblinded and getting a sense to what extent we're going to have to worry about these other cytopenia impacts.
So, Neal, do you think there's a role, maybe even in a neoadjuvant setting with a PARP in a BRCA2 patient, since there's going to be some changes coming after the ASCO presentation, presumably?
Yeah, absolutely. Great question. Sure. I love precision-based therapy. I love your earlier question about the importance of testing. And yeah, if I found I was BRCA2 and I had prostate cancer and I was localized and I was contemplating active intervention, whether it was prostatectomy, radiation, or focal therapy, I would absolutely want to leverage that alteration.
Yeah. All right. Well, I think we're hearing really a general consensus from our group that we're sort of finessing this area of mHSPC or APMN. What's important here is now learning about what's emerging, as I'll now take us through the role of AKT inhibition in patients with this group. Again, getting down to, as Fred was saying, not just the intensification, but optimization, understanding who gets what. For many years, I think many of us have known that PTEN deficiency does not do anything favorable in prostate cancer. And there's so much preclinical data as well as human level data that has shown that PTEN deficiency leads to activation of the PI3 kinase AKT pathway. And in doing so, this type of signaling provides a complementary driver of proliferation. So in certain patients, there is a strong biological rationale for dual pathway targeting, much similar to what Neeraj was saying about BRCA patients. It's really trying to think about the role of androgen receptor inhibition and. So this concept of and really understanding who gets what is critical. As we really think about what does this mean from a patient level benefit, I think it's safe to say that having this deficiency, it's associated with a shorter time to castration resistance. So as we live and try to expand so much time and other markers that are important to patients, the longer time you are in this particular hormonal state of sensitivity, the longer time you have to not change treatments, not have additional imaging, not have to figure out what's next. In this study, for example, you can just see that there's a difference just based on these patients using immunohistochemistry between the deficient and proficient patients. So it's starting to really show us the importance of having PTEN deficiency be recognized. Some of the evolving paradigms, again, not just even including about imaging-based options for the future, when we're thinking about sort of all-comer options and now even discussing about the BRCA2 alterations, 25% of our patients in the earlier stage are PTEN deficient, and specifically defined as greater than 90% PTEN deficiency. And so there's a nuance to that because it matters in some sense how much deficiency or lack thereof is provided. As you can see in just a regular immunohistochemistry, when you see PTEN proficient, when you do that PTEN stain, it's all over in brown. When you're seeing deficient, you can see that there's really lack of staining. So there's an important sort of clue that is actually beyond what you find in genomic testing. This is your standard immunohistochemistry that you would ask your pathologist. And there are some nuances. There's been additional trials in the MCRPC state that uses NGS technology. It can, of course, that technology can look at mutations in several targets. But I think when it comes to really understanding the protein expression, there's really nothing that beats your card-carrying immunohistochemistry test, which again has probably much more ability to scale up in the globe, better access to all around, again, around the globe, and perhaps more reflective of really what's happening in the cell in our particular patient. So as many of you know, the Capitella 281 study was done in this group of patients, over 1,000 men that have had their immunohistochemistry be in eligibility criteria. So again, the cutoff was greater than 90% of viable malignant cells that have no specific cytoplasmic staining. And as you can see, half the group got capivasertib plus abiraterone and ADT, so again, a different triplet intensification, as Dr. Armstrong had alluded to, compared to placebo plus abiraterone and ADT. And a variety of endpoints were looked at, but the primary one was investigator-assessed rPFS. And then a slew of other secondary endpoints that are very important, not just for us to recognize, but I think for patients, as this really reflects on what's happening. So here we see an increased rPFS survival rate. You could see a hazard ratio of 0.81 between the capivasertib arm and the placebo plus Abi arm. And just of note here, if you look at the median rPFS in the placebo Abi arm, it is at 25.7 months. That is considerably worse than our Latitude arm, where it was at 33 months. So just again, gathering a group of men that are not going to do well in their aggressive cancer. In their manuscript, it really does show a difference potentially in the median rPFS levels based on the cutoff. So they did a post hoc analysis, if you can look down here, where the PTEN score was greater than 95%, 99%, 100%. And just overall, if we look at all comers, it won't be enough. But here is, again, a nuance of a study, whether, again, it's BRCA2 only or the HRR group, in this case, P10 greater than or equal to 90%. The overall survival was a secondary endpoint, and this hazard ratio is still at 0.9, so this data is still quite immature. So lots more information, I think, to come from this group. But you also start to see the secondary endpoints, including increased time to first subsequent therapy being prolonged with the capivasertib arm. Similarly, increased time to first symptomatic skeletal event is also prolonged. And of importance, just the baseline parameters not on this slide of men who have had issues with cord compression or requiring radiation or some sort of intervention was actually quite higher overall due to the poor and aggressive disease population. Interestingly enough, you can see this is what the time to PSA progression was in the arms with a hazard ratio of 0.73. When I look at this slide, it tells me that when we see imaging progression, you don't see it with PSA progression, which really is quite frightening for us in clinic when you're thinking you have control of this cancer, you have a P10 loss that's identified, sure, their PSA is looking wonderful, perhaps undetectable most of the time, but their imaging is progressing. So we have a different biology of aggressive behavior from having this P10 loss. Again, this post hoc analysis will hopefully show us more. I think there's more work to be done here to really understand the nuance. Is there truly a difference? Should we even be as aggressive as having 100% P10 loss in these patients? So that's good data to think about for the future. It's important to also recognize, like in any other novel drug, there are going to be some additional adverse events. As you can see here, there is a higher risk of adverse events with the capivasertib arm. And when we're looking at a similar curve as Neeraj has shown, you can see that the top three here are diarrhea, hyperglycemia, and rash. And I think these are effects that we're used to managing, but again, being proactive in understanding how to manage and handle this even before things are out of control and symptoms are out of control is critical. As we look at fatigue and other issues, they're probably not as severe as perhaps anticipated. So it's really up to us, should this drug move forward towards an FDA approval, to understand what some of these effects are. Now, many of us don't go around saying, I wonder if they have a grade 3 rash, because we don't think in CTCAE terms. So I put here that we tend to worry when it's greater than 30% of a rash with symptoms, on the body. But frankly, you can do something about that at grade 2. Why wait until something is severe? Yes. So I echo Neeraj's strategy of you don't wait till it's an issue. For example, you're at 10-15%, whether you have symptoms or not of a rash, perhaps you should withhold the agent here, capivasertib, until you have recovery and then go ahead and either resume same dose or lower. So very proactive way. Same with diarrhea. No one says, wow, I'm having a great time. It's greater than 7 stools per day. I guess I'll do something about that. Again, 4 stools a day for any patient of ours is already too much. Of note, hyperglycemia in this class of drug, as expected, is something that we have to be proactively managing, and this is very critical. In the study, you were not allowed in if you had a greater than hemoglobin A1C of 8, as well as having diabetes type 1 or 2 requiring insulin. So it is restrictive. Now, should it move forward, we have to be proactive in our management, as many of our patients perhaps won't fit this criteria. So having a package insert, as capivasertib is already approved for our breast cancer patients, in how to monitor fasting glucose and whatnot, is really going to be the key to success should this drug move forward. And here's also for fatigue management as well. So it's really critical to know that, new drugs are wonderful and we're excited, but being proactive in managing any of the known side effects will be the key to our success. So I'll stop there and move on now to Dr. Love having a discussion with Drs. Armstrong and McKay.
Another new triplet in hormone-sensitive metastatic disease is the AKT inhibitor capivasertib, which in combination with abiraterone in the phase 3 Capitella 281 study demonstrated improved radiographic progression-free survival in patients with PTEN deficiency.
We know that in the metastatic hormone-sensitive setting that PTEN loss is a poor prognostic indicator. It actually is a predictor of what we call radiographic discordant progression or aggressive variant or even neuroendocrine disease. And we've recently published in JCO on this occurring in ADT-RP patients. About a quarter of all radiographic progression events are occurring without a PSA rise at all. So I'd like the panel to comment on how they will follow and monitor their patients, not relying solely on PSA. How often will they recommend imaging and what kind of imaging?
The thing about it is PTEN IHC testing can be pretty clunky. And if CAPI becomes approved, my suspicion is that many of the next-gen companies like Tempus and Foundation and Caris, they'll add the IHC test onto their assay. That would be my hope, so that pathology labs don't need to muck around with, not to say reporting out on it. It can be pretty clunky at the institutional level to ensure that there's appropriate reporting out.
Absolutely. Well, maybe before we dive into this discussion and those two thoughtful questions, as this audience and this panel knows, this compound was up for discussion and a vote with ODAC. And again, full disclosure, I was there not as a panel member, but would love to get some impressions. Perhaps Dr. Agarwal or Neeraj, thoughts on how the ODAC hearing went?
Absolutely. If capivasertib, and I hope it happens, gets approved, IHC testing of the prostate tumor tissue will have to become standard of care. By whether it is done through our individual pathology labs or it is taken up by all those CLIA certified NGS testing labs, but it will have to be done for multiple reasons, including the fact that PTEN deficiency can be missed by NGS testing if there are no mutations causing PTEN deficiency. So answer is yes. Tumor tissue immunohistochemistry will have to become standard of care.
Dan, what were your thoughts on the ODAC and sort of just your thoughts on capivasertib and PTEN loss?
I mean, it's clearly a poor prognostic factor, and I think certainly this issue about the discordance between radiographic and PSA progression is going to be very, very important. I think now we're really moving into the molecular era where we are going to be testing for PTEN. We're going to be testing for BRCA. Perhaps we'll be doing PSMA PET scans as a way of determining whether somebody should go on radioligand therapy. So this is going to make this state of disease a lot more complex. And I hope we don't run out of tissue at the same point. But that's going to be another issue. But certainly I think this is going to be very, very important. And the question is, what's the right tissue to look at? Is it better to look at the primary tissue? Is it better to look at the metastatic tissue? There's a lot of questions that could come into play as far as that goes.
Yeah, and I think the Capitella 281 was in the de novo population, so most people got metastatic biopsies, but of course, if there was nothing to biopsy, which would be unusual, you could go to the prostate. But Fred, what are your thoughts on all this conversation happening with ODAC in the States, and how do others outside of the United States feel about it?
Look, I think this is where we want to go. We want to have options that are based on biology and science, and this is really another step forward. So having this information, having a drug that targets that problem is extremely important, and I think we need to have these options available. Now, whether we're going to use them in all patients, in selected patients, how we're going to select, and how we're going to integrate. I mean, PTEN deficient patients can respond well to chemotherapy. So, you might imagine a triplet with chemotherapy followed with maintenance with this kind of agent. I mean, we have to start thinking outside the box to maximize the outcome. And how we follow these patients clearly has to be with more than PSA. That is something that we've all been burnt if you follow with only PSA, especially in these patients. We have a pathology expertise, and we've been doing PTEN for a long, long time, for over 10 years. So it's a routine that we get PTEN on high-risk disease, even localized. And that sometimes helps us to decide how intense we want to treat those patients that are PTEN deficient at the time of diagnosis.
Yeah. Neal, your thoughts on the ODAC discussion and really sort of the very, I think, very thoughtful discussion about toxicities and management and sort of that shared decision-making conversation with the patient?
Yeah, I thought the congratulations to the ODAC team that presented and got that successful 7-1 favorable vote. I've been routinely doing IHC testing because I was involved in another resistant disease state called the iPotential trial with Chris Sweeney and Johan de Bono. And so I've been routinely getting IHC testing with the sponsors that I use to get my NGS, and they have no problem. I just insisted upon it, and they're doing it. Our local pathologist is now doing it too. In fact, we're even pushing to getting IHC on her too as well. So this is very achievable. Your slide demonstrating the differences and forgetting it was really, really good. The safety toxicity management, it's real, and so people have to get their arms around the hyperglycemia issues. The rash, we've addressed rash before with the checkpoint inhibitors. It gets back to your earlier question. Look, if you're a uro-oncologist, you got to be prepared. If you're not, work with your medical oncologist.
Yeah, no, absolutely. And Neeraj, just in terms of imaging, I think Dr. McKay asked a really great question, right? We're used to the standard fare of you image when you progress on PSA, and then you're off and running with every 2-3 months based on the castration-resistant or state. But what would you propose, and what would you do even in your PARP patients? Are you imaging with standard imaging every 3 months? Are you doing PET scans?
Absolutely. So these patients, historically, in my own experience, patients with PTEN deficiency have more aggressive disease, and they don't necessarily respond to chemotherapy as well. So my practice, and when we saw the data from the Capitulo trial, that 1/3 of these patients experience radiographic progression without meeting the criteria for like PCWG2 criteria or 3 criteria for PSA progression. That was quite telling. And these two, my own experience and these data from the trial really will enhance my practice, if you will, to continue to have CT scans and bone scans every 3 months in these patients.
Mm-hmm. Well, I think that's, again, perhaps a revisitation of should this move forward. And I guess, Dan, if capivasertib was approved, would you offer it to your patients?
Yes. Oh, you asked me? Sorry.
That's okay. I would offer it. I mean, we see the data that these are poor-risk patients. This may improve overall outcomes, so certainly I would definitely offer it.
Okay. Thank you. We are going to move on and listen to the conversation with Dr. Love and O'Shaughnessy on this topic.
While few GU cancer investigators have actually used capivasertib, the drug is already approved in breast cancer. And to provide a window into tolerability issues with the agent, I asked breast cancer investigator Dr. Joyce O'Shaughnessy for her real-world experience with capivasertib.
First of all, I'd say Capi is a very well-tolerated drug. You know, there is some loose stools that you get, but then you take your 3 days off. Right when you're getting loose stools around day 3-4, then you stop. And for the 3 days off and the diarrhea goes away. You don't really get it day 1 very much, a little bit grade 2, so it's not that much. And usually patients quickly figure out maybe 1 Imodium a day or 2 Imodium days 3 and 4. That takes care of it, and then day 5, it kind of peters off. I don't think the diarrhea is a big deal. I do think rash is a thing to prevent with capivasertib, so I do think the non-drowsy antihistamine is important. I try to go BID. You can't really treat the rash that easily. You can give pulse steroids, and sometimes it works, but preventing the rash with the non-drowsy antihistamines, I think, is a good strategy. So I go BID, and then after like 6 or 8 weeks, I back it off. Like so many of our meds, the toxicity is tachyphylax. Capi is a drug patients can be on for a long time. It doesn't have cumulative toxicities.
All right. So, as usual, we're learning from our breast cancer colleagues. And I guess in this situation, as we're thinking about how to do this, Fred, would you do anything specific to this group of patients to inform your practice, for example, to anticipate any of the side effects that Dr. O'Shaughnessy was mentioning?
Yeah, I think that's whatever we prescribe, we have to be conscious of the side effects, and we have to inform. The more we inform the patient, the less they're surprised, the less they're likely to stop therapy. The worst thing that can happen is that patients are surprised and just stop and say they don't want to go back. So anticipating allows us to be able to have time to dose reduce, dose interrupt, and keep patients on to get the maximum effort. We live this with talazoparib. If we didn't follow patients properly, the trial might have failed, but we were able to manage these patients to make sure that they stayed on drug, and even with dose reductions, we got all of these great results. So this is what we need to learn. Same thing with docetaxel. ARPI is not a big issue. It really doesn't add much to ADT.
Yeah.
So really, these new agents we're going to have to experience. But knowing their PTEN will not only dictate the way we treat, but will also dictate that we need to follow these patients differently than the standard patient that ADT, ARPI, and that we can rely on PSA. Just a minor point. I mean, all of these studies have that problem that a lot of patients progress before PSA progression because the definition was 2 plus nadir. And when you're on a very powerful ARPI, you don't need to have a 2-point increase in PSA before starting to see problems. So you have to be conscious. Any PSA rise, and in some cases even without PSA rise, you have to be re-imaging.
Yeah, and I think with these nuances, Neal, you are obviously in a hugely successful urologic practice. What would you tell your fellow colleagues who feel that they see maybe a subset of these folks more than their average academic center, for example? Would you say that this could be used safely by community-based urologists, or would you encourage collaboration, or how would you advise?
Yeah, I think it starts with the education on IHC testing. It starts with the further education to make sure they're already doing some germline and somatic NGS. But the IHC is going to be very surmountable with the pathologist, the anatomical pathologist, the molecular pathologist, or whatever organization they're sending it out to. Yeah, I think the education has to be there in terms of Dr. O'Shaughnessy, great pearls that she gave. And but you know what? I don't like to put a square peg into a round hole. If they're busy doing other things and this seems a little daunting to them, checking a hemoglobin A1C, I don't think it is. Managing glucose, managing rash, managing loose stools, I think it's eminently educationable for our uro-oncologists. But again, they have to really want to do it.
Yeah. Well, and Neeraj, I'll ask you, so there was a, A1C level cutoff of 8. I think many of us in practice recognize there's plenty of people who don't have that. How would you proceed in your practice?
If somebody has diabetes, but hemoglobin A1C is well controlled, I would say, I'll just come with a figure, 7. Yeah. And they are pretty compliant with the medications. And I can rely that on them to be compliant with the monitoring, I will feel very comfortable starting the drug. On the other hand, somebody has uncontrolled blood sugar, hemoglobin A1C is already 8 plus, 7 plus, and I cannot rely on them to monitor their blood sugars. I would be very hesitant. So I think it is a combination of patient and disease characteristic, both.
Yeah, well said. Well, thank you all for hanging on. We are now going to hear from Fred about current and future use of radiopharmaceuticals in prostate cancer.
Well, thanks very much for the opportunity, and now we're going to change direction a little bit in terms of radiopharmaceuticals. So, systemic therapies in 2026, for those who just woke up, the landscape has exploded, and this is great news for our patients. But within the landscape of mCRPC, we do have 2 radioligand therapies that are now approved and available for patients, and this is what we'll concentrate on. I'm going to go back into history. This is already almost 15 years old, the data from Alsimca that looked at radium versus placebo plus best standard of care in mCRPC patients post-docetaxel or ineligible for post-docetaxel, that showed that we were able to significantly improve overall survival. There was about a 30% reduction in the risk of death. This was amazing because this was in the same range as actually docetaxel for these patients. And time to first skeletal-related event, symptomatic event, was also significantly reduced we're using radium, and the survival benefit was seen in both patients who were post-docetaxel and patients who did not receive prior docetaxel. So the question is, does adding radium to an ARPI improve outcome in mCRPC? And this is the basis of the PEACE 3 design that looked at patients in first-line mCRPC that had no visceral mets, but presence of bone mets, randomized to the standard of care of enzalutamide, which is probably the most effective therapy for first-line mCRPC, and looked at enzalutamide plus 6 cycles of radium-223 with the primary endpoints of rPFS. So really trying to bring radium earlier in the disease setting rather than waiting post-ARPI and post-docetaxel as it's most commonly used. And the primary endpoint was met and reported as a presidential at ESMO already a year and a half ago, showing there was a significant improvement in rPFS, 31% reduction in the risk of radiographic progression, and more recently, another presentation at the last ESMO looking at the final overall survival analysis that showed a 24% reduction in the risk of death. This is about almost 6 months improvement in overall survival compared to a life-prolonging standard of care. You have to remember enzalutamide, abiraterone were against a placebo showing about a 4-month improvement in overall survival. So this is really quite outstanding in a disease setting that's hard to get a handle on improving outcome. Now, switching gears to the other radioligand that is got a lot of tremendous interest is using PSMA PET to identify lesions and combining this to an agent that would deliver radiation therapy specifically to these PSMA-expressing tumors. And so the radioligand lutetium PSMA 617 is the most the only one that's approved right now for common use. And the first single-arm study showed very significant PSA responses in patients that were heavily pretreated with a very significant also overall response rate. And then subsequently to this, the Australians did a randomized study post-docetaxel comparing cabazitaxel to lutetium and showed that you were able to get better PSA responses with lutetium, better progression-free survival with lutetium compared to cabazitaxel, better objective responses, better deterioration-free survival, so maintaining quality of life for a longer amount of time, and less adverse events compared to cabazitaxel. So this led to a big interest of using lutetium instead of cabazitaxel in patients that were felt to be appropriate and expressed PSMA. And then the trial that led to the approval of lutetium was the VISION trial, looking at patients post-docetaxel, post-ARPI at the very least, and showed that rPFS and overall survival were significantly improved with lutetium over best standard of care in the VISION trial. Now, the question of PSA response was better, as you would expect in these patients, but what really was outstanding was the measurable response rate. So we had about a 10% complete response rate in these heavily pretreated patients and almost about a 20% partial response. And quality of life was improved by using lutetium. Now, the question that often comes up is, are patients benefiting? Can we get a signal before going through 6 cycles of lutetium in patients that are running out of options? And this is a paper that came out of VISION that are presented here at AUA and subsequently was published with Andy Armstrong, looking at rPFS and overall survival after 2 cycles of lutetium. So if PSA is not declining by at least 50%, there has to be serious consideration of whether or not you should be continuing the lutetium if there are other options that are available, because these patients will progress very quickly if they're not getting at least a 50% PSA decline, and overall survival is going to be around less than a year if they're not declining at all in terms of PSA, compared to patients who are getting a 90% decline, where at 3 years we're not even at the median survival. So really easy to distinguish patients that are more or less likely to benefit. And then more recently, the PSMA 4 study looking at taxane-naive patients, so bringing the lutetium earlier in the disease setting. And here there was a very high crossover rate, so patients were compared to lutetium to a switch in ARPI with a crossover. But RPFS was clearly met the primary endpoint. Overall survival was not significantly improved in the study, but considering almost 85% crossover, this was to be expected to a certain extent. But here again, PSA response, 51% compared to 17%, but again, 50% measurable response, 21% complete measurable response, 29% partial. This is not what we see with chemotherapy in this patient population that have progressed after an ARPI. So I think something that is an alternative to going to chemotherapy post-ARPI, especially given the fact also that the quality of life appear to be longer preservation of quality of life and delays of pain progression in patients going on to lutetium. And then the most recent PSMA addition, now bringing the lutetium into the hormone-sensitive setting, looking at patients getting ADT ARPI, the best standard of care, plus or minus lutetium. Primary outcome, RPFS had been reached, 28% reduction in RPFS by adding lutetium to what is considered the best standard of care of ADT and ARPI. And overall survival still immature, but trending in the right direction, and there's going to be an updated presentation hopefully in the next few months. Quality of life, looks like we're not worsening quality of life. These patients usually have good quality of life coming in, but at least we're not making it worse by adding lutetium. And this I presented just before this session in terms of PSA responses by adding lutetium to the best standard of care. And you see we go from 74% undetectable PSA below 0.2 up to 87%, so close to 90% getting to under 0.2 by adding lutetium, and getting to less than 0.02, which is a higher bar and probably not what we need to do. But we go from 46% up to 65%, and all of these hazard ratios and confidence intervals do not cross. So we can't talk about statistically significant, but clearly there seems to be a benefit by intensifying or optimizing care over ADT and ARPI. And there was a significant delay in time to PSA progression of a 58% reduction in PSA progression. We haven't heard the end of radioligand therapy. There are multiple trials, both with beta-emitting agents, alpha-emitting agents, in combination therapy, just too much to discuss, but this is a field that's exploded with interest. And just one example that was presented at ASCO GU that I presented, a phase 1 dose escalation study that showed that at the 125 dose of this actinium compound, we got 83% response. And this is post-docetaxel, post-ARPI setting, 73% measurable response. And this is the kind of responses we saw after only 2 cycles, almost complete disappearance of lesions and PSA plummeting to undetectable and maintaining for now. So this trial is still ongoing and should lead to a phase 3 study. So radium-223 with a bone protective agent is a therapeutic option in both the pre- and post-docetaxel setting. ADT, ARPI plus radium may provide added benefit, and radioligand PSMA-based therapy is safe and effective. And earlier treatment seems to be even more in terms of improving outcome with less heterogeneity. And there's ongoing research with new RLTs and in combination with other therapies. And ultimately, sequencing combinations, more lines of therapy leads to longer survival. Thank you very much.
Wonderful. Thank you so much. That one last slide alone will keep us busy for a long time. We're going to now hear from Dr. Armstrong about his conversation with Dr. Love.
Another triplet that may become an option in hormone-sensitive metastatic disease is lutetium-177 PSMA-617 in combination with an ARPI and ADT, which led in the PSMA addition trial to improvement in radiographic PFS.
PSMA radioligand therapy, particularly lutetium-177, has really changed my practice over the past 5 years, and many patients are eager to receive this new smart bomb therapy to put off, for example, chemotherapy. The PSMA addition study demonstrate progression-free survival benefit, but not yet a survival benefit. And I wonder if the panelists could comment on their overall sense of the risks and benefits of using PSMA radioligand therapy early, whether we should be using all 6 doses, a sandwich approach of a couple doses here, a couple doses there, or should we be saving this for later, given its effects on bone marrow, clonal hematopoiesis, and the risk of MDS AML theoretically that could emerge later?
Great question. Perhaps, Fred, you'd like to try to answer what Andy's question.
Yeah, so we have to start somewhere. So usually we start with the dose that's approved in other disease settings, like we did with all the other drugs. But obviously the question begs, do we need to give all 6 cycles in these patients that are hormone sensitive when, if we image these patients, there's complete disappearance of any visible lesion? That's a question that we need to address. But I do think, based on the data that we have, that we're heading in the right direction for another triplet that doesn't really require any molecular alteration specific beyond being PSMA positive. So I think it's going in the right direction. Improving on ADT and ARPI is a really, really high bar. Mm-hmm. And this PSA results actually surprised me. This is something I was very interested in. But we seem to be getting close to where we want to go. Close to 90% undetectable, I think, is where we want to go.
Yeah, I think those are the responses we want for this early group. Neeraj, just thoughts on xerostomia? Are many of your patients seeing this? How are you helping to mitigate it?
It's not universal. And coming back to Fred's point, if I'm giving somebody lutetium after 2 cycles, and if the PSA is undetectable and PSMA PET scan is not showing any uptake in a metastatic hormone-sensitive prostate cancer, all that extra drug is going to go to somewhere else. Yeah. So prevention of xerostomia is always dependent on dose optimization to begin with, in my view, and then taking care of precautions. And there are multiple precautions which can be taken regarding, their supportive measures. But there is no one foolproof mechanism in my experience. If it is going to happen, it will happen. And the key is to not overdose, not give too much dose than patient need. And I think that's the best strategy to prevent or optimize or the occurrence of xerostomia.
Oh, great answer. We are now going to listen to Drs. Armstrong and Srinivas in a conversation with Dr. Love.
I was curious about new approaches to androgen pathway modulation, and Dr. Armstrong brought up a fascinating new agent that, interestingly, seems to be particularly active in patients with androgen receptor mutations.
Opevestat, or OPI, is a CYP11A1 inhibitor. Think of this as an adrenollytic where you have to replace dexamethasone, you have to give fludrocortisone because of the adrenal insufficiency toxicities. And Merck is doing these 2 phase 3 studies, particularly in AR-LBD mutation positive patients, but also in all comers, really looking at progression-free and overall survival as compared to a second ARPI. I'm interested in the panel's thoughts around OP, whether they feel like it will have a role, particularly in the LBD positive patients, how they'll go about detecting AR mutations, which seem to enrich for OP benefit, and whether they think it'll be a broadly applicable adrenal steroid synthesis inhibitor, much like abiraterone was.
I'm very excited about that drug. Drugs that alter the AR pathway is very relevant in this disease. I don't know if it's a drug that's going to be applicable to all patients, or would it be just to a niche population about those who have AR mutations? These sort of drugs have a huge advantage of being oral, manageable side effects, and being very accessible to medical oncologists and urologists. There are so many choices now in that space. CRPC is so crowded. How would they choose this drug, and how do they screen for AR mutations?
Incredible questions, of course, from our experts. Neal, let me ask you about what your thoughts are on OP.
So we're not doing the OPI, but I'm doing another very comparable, the ACE-RAN trial with Emmanuel Antonarakis. I believe he's the PI, and I have about several patients on it. It's quite comparable. Mm-hmm. When you start to have to, balance, dexamethasone and fludrocortisone, and look at, the adrenal pathway side effects of this, in addition to hypertension and some of the other metabolic issues, I actually am finding it not that challenging personally, but I wonder about this for the uro-oncology community. I think this will probably, if it does lead to approval, it'll probably be much more, you'll see greater utilization with medical oncologists.
Mm-hmm. I think there's a lot of, obviously, emerging targets. Dan, you have run several trials and involved in those with PROTACs. Just some thoughts there.
Well, we know that the androgen receptor is apparently activated by other ligands, and certainly we've seen some really interesting data with ARV-766, which is a PROTAC that hits 5 different androgen receptor mutations. But the interesting thing I think about this class of drugs is they also are probably about the strongest upregulators of PSMA. Mm-hmm. And we just completed a 3-arm study looking at lutetium PSMA combined with ARV-766. And we'll see what that data is going to show in the next couple of years. But there are some very, very exciting other approaches. There are other PROTACs that are being evaluated in this situation. And certainly this portion of the androgen receptor is interesting to look at. And the other thing I think now that's also coming to play is something called RIPTACs, which are very, very exciting and use the androgen receptor to basically metabolically alter prostate cancer cells. So I think a lot of exciting data coming about.
RIPTACs are really quite unique. I wonder, though, Neeraj, again, we've talked a lot tonight about testing and how are we testing for these things? Is this sort of an assumption it's happening because the androgen receptor pathway is always at fault, or how are we going to get down to this nuance?
If these agents get approved, I think CLIA-certified commercial companies will be very quick to adapt. We order ctDNA testing through these companies, and I hope that they will start doing those tests for looking for AR mutations and AR amplifications. So I'm really hoping that will happen, because otherwise it would be very difficult for individual clinics or hospitals to perform these tests.
Mm-hmm. And Fred, I know in your slide with PSMA, obviously the N-terminal tends to give us problems as well. Just thoughts on tackling that as opposed to the C-terminal end?
Yeah, I think that's a challenge. That's why going upstream might solve a lot of those problems of trying to tackle the androgen receptor, but maybe tackle the production of androgens earlier on. I think can solve the problem, and I'm very interested in looking at ways to enhance the likelihood of a PSMA radioligand therapy being even more effective. And now we're starting to work on bispecific or on STEAP combined with PSMA targeted, trying to address the PSMA non-expressing lesions that remains a challenge, whether it's in combination or with some of these new agents.
Yeah, and I think, Dan, I might have you get the last word in terms of other emerging agents like deruxtecan, just in that class of drugs. Thoughts there?
I mean, I think some of the exciting agents that are coming about are the bispecifics. I mean, I'm really, really excited about some of the responses we've seen. Some of them are very, very durable, and this is really going to change. And we thought of prostate cancer as being an immune desert. Yep. And I think now we found a way to bring water to the oasis to the desert in this situation.
Yeah. Well, that is really another emerging field with cellular molecular bispecific therapies and T-cell engagers. And we in medical oncology have to hang out with our hematology colleagues. So really a multidisciplinary effort, I think, for all of our prostate cancer patients. I know that we have had such a tremendous time this afternoon and evening. Thank you for those here in person as well as online. And thank you to my esteemed panel for serving up their really expert insight on such a rapidly evolving field. It's been a pleasure to serve as your moderator this evening. I wish everyone a safe trip home. Have a wonderful evening and the rest of the week. Thank you.